Good afternoon, everyone, and welcome to today's public lecture sponsored by the John C. Danforth Center on Religion and Politics at Washington University. I'm Marie Griffith, the director of the center, and I'd just like briefly to highlight a couple of events that we have upcoming. This Saturday, October 10th, we are co-sponsoring the local launch event for Senator Danforth's new book, The Relevance of Religion, How Faithful People Can Change Politics. Even we don't have our copy yet. Its publication date is in a couple days, but it's being published by Random House, and the event takes place at 7 o'clock this Saturday night in the main reading room of the St. Louis County Public Library on Lindbergh Road, the headquarters of the library. Senator Danforth will be interviewed on stage by McGraw-Milhaven of KTRS, and this will be followed by Q&A with the audience and a book signing. It is a ticketed event. There is a small cost to it, and you can purchase tickets online at the St. Louis County website, and a ticket does include the price of a book, and of course you'll get the autograph and all that. So please ask us afterwards if you have any questions about that. And then on Monday, November 2nd, the center will be co-sponsoring a public lecture and book signing by Rabbi Lord Jonathan Sachs, a global religious leader who will discuss his most recent book, Not in God's Name, Confronting Religious Violence. The book explores the roots of violence and its relationship to religion, focusing on the historic tensions among Judaism, Christianity, and Islam. So this event, this is November 2nd, and it'll take place as part of the St. Louis Book Festival and will be at 7:30 p.m. in the Jewish Community Center. Today is the second in a 4-lecture series on religion, medicine, and law that has been organized by Professor Lee Schmidt. And next in the series will be Dr. G. Scott Morris of the Church Health Center on November 3rd. He's going to be lecturing on the faith community's role in healthcare. And that lecture will also be here at 4:30 p.m. And the series will conclude on December 1st with the University of Toronto's Kevin Lewis O'Neill, who will speak on Christian drug rehabilitation centers in Guatemala. Today, we are delighted to welcome as our speaker Wendy Cadge, Professor of Sociology at Brandeis University and Chair of the Women's Gender and Sexuality Studies program there. She earned her BA at Swarthmore College and her MA and PhD in Sociology from Princeton University. She has held important fellowships at Harvard University, and she taught at Bowdoin College before moving to Brandeis. I cannot introduce her without noting that Professor Cadge's first professional position was serving as the acting associate director at the Center for the Study of Religion at Princeton University. She was acting for me. So she and I have a couple of things in common, and she knows centers like ours really well, and it's a great honor to have her here with us today. Professor Cadge has received numerous research grants and awards. I'm not going to list them all. She's got a very impressive CV, but most impressively, I think, she currently serves as the co-leader of a multi-million-dollar Templeton Foundation-funded project titled Training Research Literate Chaplains as Ambassadors for Spirituality and Health. She is a widely published, reviewed, and cited expert in a number of areas, and she has a lengthy CV, as I've said, filled with public and scholarly presentations in a wide range of venues and significant publications relating to religion and healthcare, among other subjects. Her first book, Heartwood, is a fascinating ethnography focused on the first generation of Theravada Buddhists in America, focusing on 2 Theravada communities in the United States, one composed largely of Thai immigrants and the other consisting mostly of white converts. She's the co-editor of an important collection titled Religion on the Edge, Decentering and Recentering the Sociology of Religion, and her most recent single-authored book is Paging God, Religion in the Halls of Medicine. Please join me now in welcoming Wendy Cadge as she delivers her lecture for us, Paging God, Religion in the Halls of Medicine.
Hi, everybody. Thanks, Marie, for that very kind introduction. It's really a treat to be here. I want to thank Lee for the invitation and Marie for having me and hosting me, and Sherry for dealing with 1,000 details. It's always a treat to get to talk about my book, Paging God, Religion in the Halls of Medicine. And what I want to do with you this afternoon is think about what it has to say about religion and medicine and the law, which I know is your theme for this fall. I thought I'd start by introducing you to this man. This is Tan Jalkun Ratanamati. He's a Thai Buddhist monk born in Thailand in 1938. He was trained in sociology and in political science at Pune University in India, and he came to Philadelphia in 1985. So in 1985, there were a group of Thai immigrants, mostly between New York and DC in the Philadelphia area, who wanted to start a temple. Now, if you're a Thai Buddhist immigrant and you want to start a temple, the thing you must have first is a monk. So they literally called their friends in Bangkok, and they said, "We need a monk. Could you send one?" And there's a big temple outside of Bangkok called Wat Bak Nam. Tan Jalkun was living there at the time, and he and another monk were sent to Philadelphia to help to start this temple. So he arrived in Philadelphia. The group had gathered. They'd raised some money, but they had no building. So he went to New York, and he stayed at a temple there. Eventually, they bought a very small Cape Cod kind of house, and he and his fellow monk moved into this house. Over the coming years, they built a very large Buddhist temple and then another very large Buddhist temple, all on the same plot of land in Ben Salem. It's about 25 miles north of Center City, Philadelphia. And today it's got spires. It looks just like it could be in Bangkok. So I met Tan Jalkun there at, it's called Wat Mongkol Temponi. They call it Wat Phila, which is Phila, short for Philadelphia. I met him there in 2000 when I was conducting research for my first book, which focuses in part on Thai Buddhist immigrants to the US. Now, what I didn't know when I met him was that he had liver cancer, and he was going back and forth from Philadelphia to Texas to be treated. I suspect he was going to MD Anderson Cancer Center. I never talked to him about it directly. And I know that he was doing the traveling because he wanted to be treated by Thai-born and Thai-speaking physicians. Now, near the end of his life, he was too ill to travel, and a Thai physician who was involved with the temple there helped to have him admitted to a local hospital, one just down the road from the temple. I was invited to visit him in the temple, in the hospital, which I did. And I saw him just a few days before he passed away. I entered the room with some Thai friends, and Thai etiquette is that when you're in the presence of a monk, you always keep your head below the head of the monk. So we entered and literally crouched down at the end of the bed, and he was sleeping in the bright orange robes here of the monk. This is a picture of him on his birthday. They would have a special celebration, and people would pour water on his hands, and there'd be some chanting and blessings. So we're crouched down at the end of his bed, and we're watching him sleep. And I thought, how is this hospital going to respond, going to try to care for a Thai monk differently than they might care for you and I? And I thought, what about many of us for whom religion or spirituality could matter in healthcare institutions, but we're not wearing it so brightly on our chests, right? We're not wearing the bright orange robes of the monk. So Tan Jalkun woke up. I spoke to him briefly. The people I was with had brought in Shore protein shakes, so we donated them, and they were forming a big stack under his bed. And he passed away here in this hospital just a few days later at an auspicious time on an auspicious day, which is all about the lunar calendar, but for people with Christian backgrounds, it was actually Holy Thursday or Maundy Thursday. So it was this experience that led me to come to write this book. And what I thought about at the time, and then thought about many more times over subsequent years, is that it's many of us for whom religion and spirituality matters when dealing with health. These are just a couple of quick numbers for you, some recent surveys that suggest that 70 to 85% of Americans regularly pray for their own health or the health of family members, that more than 3/4 of Americans believe prayer can have a positive effect on people who are ill, and that close to 3/4 believe God can cure people given no chance of survival by medical science. That to me is an astounding number, 3/4. I'm noting a study here published in the Archives of Surgery a few years ago in which researchers found that 60% of the public and 20% of medical professionals think that people who were in a coma, in a persistent vegetative state, can be saved by a miracle. I'm actually collaborating with a group of healthcare providers at Mass General Hospital right now, and we're looking at the cases that come to their ethics committee where there's disagreement about life-sustaining treatment, and we're looking at a number of things related to them, but one of them is about religion. And it's not surprising to me when we hear this number, that 60% of the public and 20% of medical professionals think it's possible for someone in a coma to be saved by a miracle. That's not a surprise to me then when we find that family members often don't want to, quote, pull the plug. So we can talk more about that in a bit if you want. The relationship between religion, spirituality, and health has been of interest to scholars across the disciplines for a long time. But in my experience, they usually speak different languages, and they usually ask different questions. So lots of people want to know if religion makes you healthier or not. I have religion and health on a Google alert, and I get news about that almost every day. Many of these articles have been cataloged in PubMed, so PubMed is the main biomedical search engine, and this is just a picture to show you that over time, the number of articles that address religion or spirituality and health has increased quite significantly. There are lots of medical educators, especially some that I've come to think about as being a part of a sort of spirituality and healthcare movement since the early 90s, that have tried to train healthcare providers to do and learn and know more about religion and spirituality. And there are lots of different models. So this is the webpage of the George Washington Institute for Spirituality and Health, led by Christina Pulchowski, who's a physician and a member of a Catholic religious order. They have a lot of programs to try to provide training, mostly to physicians, but also to other health professionals about religion and spirituality. The University of Chicago has a big program on medicine and religion. There are sort of chaplaincy training programs that are oriented to chaplains, of course, but also to healthcare providers. We have one of those in Boston at Mass General Hospital. Despite this sort of interest, when I started this project, there was very little written about how healthcare organizations actually think about religion and spirituality and address it. We see lots of newspaper articles. They almost always report about conflicts. So this is a clip that I brought down from the American Medical Association. And there are always conflicts about, medicine versus miracles, or religion versus, what can happen in biomedical science. Often there's mention of children for a lot of good reasons. And I'm not denying at all that religion is a source of conflict, but I wondered sort of about what the bigger picture here was. And in a lot of these articles, there are a lot of shoulds. What should doctors do? What should religious professionals or parents do? Richard Sloan is a researcher at Columbia University. Many of you may have heard of his book, Blind Faith, The Unholy Alliance of Religion and Medicine. And he makes the case that really healthcare providers should not deal with religion really at all. I read all of this and I thought about it, and what I wanted to do was put the shoulds to the side. I didn't want to ask a normative question. I wanted to ask a descriptive question about what forms religion and spirituality actually take in medical settings. And I thought once we knew more about the organizational piece, then we could think about the shoulds, and I'll say something about the shoulds at the end of my talk. But my approach here was to first put them to the side and to be really a sociologist. So I spent more than a year interviewing 150 physicians, nurses, chaplains, chaplaincy directors, social workers, and other healthcare providers. I focused on the 17 largest academic medical centers across the US, so the one that you will be most familiar with here in St. Louis is Barnes Jewish Hospital. There are hospitals like the University of California, San Francisco, University of Chicago hospitals, Mass General Hospital. I needed to start somewhere, and I focused sort of just on this academic tier as a way to start. I became part of the chaplaincy department at one of these hospitals for a year, where I shadowed chaplains and interviewed all of them. I also became a part of the intensive care units at another of these hospitals, where I interviewed lots of healthcare providers. My aim was to look at the historical and policy contexts that shape how religion and spirituality are present in hospitals, to look at the formal presence via chapels, meditation rooms, prayer rooms, to look at the work of chaplains, and to look at how healthcare providers respond to all of these sorts of issues. Now, I was motivated to do this in part by the statistics that I presented first, which are about patients and families. And unfortunately, I didn't manage to get access to talk either to patients or to families. So the story that I tell is an institutional story about the healthcare centers, and I'm hopeful that eventually someone will be able to tell a different kind of story, but that's not what I'm going to tell you today. So the story that I tell in the book is a story in layers, and what I want to do is walk you through some of these layers and then conclude with some of the big take-home messages. So first, let's talk a little bit about the history. It's important to remember that religion and spirituality played a central role in the development and expansion of hospitals in the US. I'm not going to talk about this a lot because I purposely focused on hospitals that are now secular, but I just don't want us to overlook the fact that Protestant, Catholic, and Jewish hospitals, many which have secularized since, and Barnes Jewish Hospital is a great example, were an important part of hospital expansion in the 20th century. The main way religion has formally been a part of hospitals has been in the work of chaplains. So this is what we know, and honestly it's not very much, about the fraction of hospitals over time in the US that have had chaplaincy services. These data come from funny years. They come from a survey that the American Hospital Association does of chaplains, or of hospitals, in which they ask a question, Do you have a chaplaincy service, yes or no? And that's it. So we don't know if it's volunteer, if they're paid, if it's one chaplain, if it's 15 chaplains. So it looks like, and when you can continue this out from 2009 to the present, that about 2/3 of American hospitals currently have chaplains. This is another picture that basically says the same thing. I don't think the early data are reliable enough to talk about change over time. But I think it's safe to assume that today about 2/3 of hospitals say they have a chaplaincy service, but we don't know what that means. The Joint Commission, which is the organization that regulates healthcare in the US, has talked about religion and spirituality since 1969. So if you're a hospital, you have to follow Joint Commission guidelines in order to get federal money. But what's important to know about the Joint Commission is that they have never required hospitals to have chaplains, okay? Before the 1920s, we think that most hospitals that had chaplains probably had retired clergy or perhaps people who couldn't cut it in other areas of religious life. But this history really has not been written. It was in the 1920s that a group of Protestant clergymen, concerned about the rise of psychological and psychiatric ideas, started trying to get Protestant theological students out of the classroom and into field education programs so they could sort of engage with actual human beings. What they were trying to do was shake up Protestant theological education. They were trying to solve a problem in the theological schools and to transform the church. Clinical pastoral education, which is the main way that chaplains today continue to be trained, actually emerged out of this effort in the 1920s. Some of the people that were key to it were Richard Cabot. Richard Cabot was a physician at Mass General Hospital. He actually paid the salary of the first chaplain at Mass General Hospital, whose name was Russell Dix, from his pocket. Richard Cabot is the physician and Russell Dix is the chaplain. Anton Boyson is another early chaplain. He was appointed as the chaplain of Worcester State Hospital in Massachusetts in 1924. So it's the work of these men and others that led to the development of hospital-based training programs for theological students that ultimately led to the development of professional healthcare chaplaincy. So I talk a lot about this development in my book. I'm happy to talk about it, but there are really just two important things to remember. The first is that chaplaincy emerged from efforts to reform Protestant theological education. And professional chaplaincy was a Protestant profession for many years. It was not until 1965 that the National Association for Catholic Chaplains was started. It wasn't until the 1980s that the National Association for Jewish Chaplains was started. And members of the early Protestant professional groups rejected non-Protestant applicants. So I was in their dusty archives out in Chicago, and I found records of them actually rejecting Unitarians in the 1950s because Unitarians were not Protestant. All of the certified chaplains that belonged to these early chaplaincy associations actually had to be members of the American Protestant Hospital Association. So we can't really lose sight of the Protestant history of this field. The second main take-home message is that chaplaincy developed not to solve a new problem. People have long been ill, they've long been needing care. It emerged because there were sets of people with new skills that they learned in these clinical pastoral education programs, which I think you can really think about as like experiential education programs. These people emerged and they thought that they could provide a service that wasn't currently available in hospitals. So from 1925 to the present, hospitals have employed these professional chaplains by choice. And this is, again, an important point that I'll come back around to. In addition to the chaplains, the second important historical factor to think a little bit about is the Joint Commission. So recent Joint Commission guidelines say, among other things, that hospitals need to respect patients' cultural and personal values, beliefs, and preferences. They need to accommodate patients' rights to religious and other spiritual services. And they have other guidelines related to food and education, substance abuse, this sort of thing. They don't say anything about how hospitals are to do this. So some hospitals will have a specially trained nurse. Some might have a volunteer chaplain. Some actually have the priest down the street that they call kind of in the event of a, quote, emergency. Chaplains have hoped for years and years and years that the Joint Commission will say that chaplains have to provide this service. But that's actually never happened. The last thing I want to say about this historical piece is about healthcare providers. I reviewed a lot of medical and nursing textbooks and curriculums, and it's really clear to me that nurses have thought about spirituality and religion and learned about these issues longer and in much more depth than physicians as part of providing good bedside care. So this is changing a bit now, but medical textbooks, when I went back and looked through all these old medical textbooks, mostly mention religion in sections related to death. The Cecil Textbook of Medicine, which is one of the sort of big major medical textbooks, first mentioned religion in 1975 in a chapter titled The Care of the Patient with Terminal Illness. Harrison has a well-known Principles of Internal Medicine textbook that first mentioned religion in 1974 in relation to incurability and death. So it almost seemed like, when you're a physician and there's nothing else to offer, it's the end of someone's life, then you might talk about religion or bring someone in to, if you want to be sort of, critical about it, say, do the mopping up work. Attention to religion has gradually shifted to spirituality in these textbooks, which authors increasingly now define as all of the ways people find and create meaning. But it's pretty clear, especially in the research about nurses, that a lot of them don't know what this means. And it's not uncommon now to see headlines in newspapers about more medical schools offering courses about spirituality, about religion. What we don't know is who takes those classes and what the long-term effects are. And I interviewed some young physicians expecting to hear that they had at least known that these classes were taking place, maybe they attended them, and I saw almost nothing. So we need some good outcome-based studies. So there's more to say about all this history, but the summary is that religion has been a part of hospitals historically. The chaplains have been the formal carriers of this religion, but has taken many forms, and chaplains were mostly Protestant. That the Joint Commission has addressed religion and spirituality, but mostly in passing. And it's nurses, more than physicians, that tended to have training in these issues. So if we put the historical piece sort of to the side for a second, I want to think now about physical spaces in hospitals. And as I got into hospitals and started to spend time, what I saw were these chapels, meditation rooms, and prayer rooms. All of the hospitals I looked at had at least one of these spaces. Often they had two because hospitals merged, and who wants to close a chapel if it has sort of historical significance? Very little has been written about the history of these spaces. Some early American hospitals had chapels, others did not. It seems reasonable to guess that they were more likely at religiously affiliated hospitals. It's not uncommon for religion and death to have been linked structurally in some of these spaces, so I found some evidence of mortuary chapels, which were chapels literally built next to the morgue with a door in between, so they could slide a body out of the morgue into the chapel. Some of the records talk about putting bodies on ice. I mean, it's fascinating. So that if families were not able to be there when a loved one passed, they could come to the hospital and see the body of their loved one. In one of the hospitals that I learned about, this space still existed, and it had become the chef's office, which is just wrong. So over time, architects have argued that chapel spaces in most hospitals have been downsized and were little more than, quote, waiting rooms off of bleak corridors, but there actually is no systematic historical evidence about this. So when I looked at the spaces at these 17 hospitals, I found a continuum. And what I want to do is show you some photographs, but I had a sort of tricky ethical dilemma here because as part of my IRB, I changed the name of all the hospitals. So I'm not showing you spaces of the hospital I actually studied, I'm showing you other ones, and I'll explain. So at one end of the continuum are tradition-specific chapels. So these are the chapels at Bellevue Hospital in New York City. At Bellevue Hospital, they have a Protestant chapel, they have a Catholic chapel, they have a Jewish chapel, and they also have a mosque that I don't have a picture of, but this is a picture of the mosque at Lutheran Healthcare, which is in Brooklyn, not far from Bellevue. So at one end of the continuum are spaces that if you were in them, you might not even know you were in a hospital. You might think you were in a church or a synagogue or whatever the case may be. In the middle of the continuum are spaces like this one. This is at Faulkner Hospital in Boston. These spaces tend to include symbols from a range of religious traditions, kind of mixed up in different ways. So I actually read this space differently than the person who introduced me to it, one of my informants. But she talks about the wood on this table came from Israel. They have a Catholic kneeler in the corner. They have books from a range of traditions. They had Muslim prayer mats in the back. So this is one example. This is another example from Riverview Hospital, which is in Noblesville, Indiana. They also have symbols from a range of traditions here. They actually invited local clergy and religious organizations to donate symbols and objects to be put in this space. So these are the sort of spaces in the middle. At the other end of the continuum are spaces that look more like this. So this is the Samaritan Pacific Community Hospital, which is on the Oregon coast. They call this room the Pacific Sanctuary, and they opened it in 2010 as a safe and protected place for all people. Another example is this one. This is in the Department of Pastoral Care at Virginia Commonwealth University Medical Center in Richmond, Virginia. They also newly renovated this chapel in 2010 and intentionally have it containing no religious images or symbols in what they see as an effort to welcome all. The thing I can't figure out about this space is where you sit. I see where you put your shoes, right? It looks pretty uncomfortable to me. If you go to their webpage, they have a marvelous video of the opening. So they invited religious leaders from across Richmond to come, and they prayed and chanted and did all sorts of things in all kinds of different languages. There's a very clear movement towards these kinds of spaces. So away from tradition-specific spaces to those that seem more neutral, more interfaith, in which religious objects and furniture are on wheels. I saw a number of examples where there were pulleys, and you could actually pull the Christian cross or the Protestant cross, the Protestant cross or the Catholic cross or the Star of David across the front of the chapel. A lot of these Lazy Susan. So in the military, early military chapels, they actually started these Lazy Susan things in chapels, so you could, rotate whatever symbol you needed, then you could close the door. So it's that sort of approach that is the case in these. So they want spaces that are versatile, that are flexible. Names have been changed from chapel to meditation room or to prayer room. Rather than filling these spaces with the widest possible range of religious and spiritual symbols and naming religion in its multiple forms, chaplains and hospitals in the U.S. very clearly to me seem to be doing the opposite, which is one strategy for responding to religious diversity in public contexts, but it's one that minimizes rather than embraces the differences. So the story I want to tell you about chaplains is actually fairly similar to this story about spaces. It's about a transition from tradition-specific chaplains to those who are working more as interfaith chaplains. So chaplains increasingly today are staffed on units. You're in oncology or you're in the ED, and you see everyone in that unit regardless of your religious affiliation and their religious affiliation. If a specialist is needed, so if you have a Catholic person who needs a priest and you're not a priest, then you can page that person. So it's not that those matches can't be made, but in general, the work is organized now by unit rather than by religious tradition, which is how it was done in the past. So to be a board-certified chaplain today, you need to have a master's degree in theology or a related discipline, the endorsement of a religious organization, 1,600 hours of clinical pastoral education, which is that training program I was talking about earlier, and membership in one of the main professional chaplaincy organizations. That said, chaplains remain largely mainline Protestant. And these are the best data that I could compile about the religious demographics of healthcare chaplains in the US. So the middle column is the religious demographics of the US population. This is old, so it was from 2007, the Pew survey. And then I combined the membership demographics of the three main professional chaplaincy organizations. And so what's interesting here to me is that about 31.8, so 32% of chaplains were mainline Protestant in comparison to 18% of the population. Only 12% were evangelical Protestant in relation to about a quarter of the US population. Many more were Jewish. 9.7% of chaplains were Jewish in comparison to the US population, and many more were also Catholic. So we can talk more about this in the Q&A. This is about training. This is about recruitment into the profession. This is about the sort of requirements now to be able to be interfaith and flexible around a range of different traditions. But it means that the people who are doing the work of chaplaincy are often quite different from the people that are being cared for. So when I talk to chaplains, and I spend a lot of time with chaplains, and you talk with them about what they do, they see themselves as people who facilitate wholeness, presence, and hope in healthcare organizations. They say the institutions tend to be more focused on pieces of people, the kidneys or the lungs or whatever the case is, and that their job is to focus on people holistically. So I write a lot about Meg in my book, one of the chaplains that I spent a lot of time with, and she told me, just to illustrate this point, that people come from all over the world to teaching hospitals, and we chaplains are the ones who make these people not be strangers here. We invite them into the community, so this becomes a safe haven, in some regards, and a place of hope. I often say I have a theology of hope. I'll say to families of patients that when you're 5, you want a red bicycle, and when you're 25, you want a red convertible. Our hopes do change as we mature and grow and through life's transitions, but the same hopes, they have to change. In these large hospitals, she says, people can often lose hope, but to lose a hope doesn't necessarily mean that you lose all hope. Part of a chaplain's task is to help people find something to be hopeful about. So she went on to explain to me that sometimes that hope is about the cure for a disease, but more often it's about healing, which Meg describes as being made whole. So she went on to say, sometimes that wholeness includes a physical response, but not always. A lot of the work that we as chaplains do is about reconciliation, that helps people to feel whole, to bring them back to what has been, to what is, to what can be, either in this life or in the next life, depending on what their theological belief system is. Now, many patients at teaching hospitals have come from long distances, so it's not that local clergy are not there and can't and don't do some of this work, but for people like Meg in the hospital where she was often taking care of people whose families were, hundreds of miles away, so the local clergy person wasn't there. As chaplains do their work, many of them struggle with getting these perspectives about wholeness and hope recognized, and also with questions of authority. Really, the question is, on whose authority do chaplains do their work? So I talked with them about this, and some of the chaplains told me that it's God, or a sense of the holy, that compels them to do this work. But that can work for people, but the question then is, how do people who don't believe in God fit into that picture? Some of the chaplains wanted to talk to me about data or empirical research. There's evidence that the work that they do leads to better outcomes. And unfortunately, that's actually not the case. Not because people haven't tried to do the studies, but there just isn't a lot of research that tries to connect spending time with patients to better health, things like that. Other people also talk to me about chaplains' training and certification, which prepares them for the work, but often kind of misses the point, because it's not about how well prepared you are to do the work. The question is about on whose authority you're doing the work. In the last 15 to 20 years, professional chaplains have mostly adopted a language of spirituality to try to answer these questions about authority. So what they're trying to do is say in different ways that their authority to do the work comes from their belief that all people make meaning, that our meaning-making experiences are challenged when people are ill or facing a crisis of health, and that chaplains are people trained to support people as they move through these challenges of meaning. This is what I think about as the sort of professional manifesto of professional chaplaincy. They're working on a revision now. This last one was published almost 15 years ago. And in this document, the authors adopt the language of spirituality as a way of bridging religious differences and trying to articulate a common professional purpose. So amongst other things, this document says that, quote, persons are not merely physical bodies that require mechanical care, but individuals in need of time-tested spiritual resources. By helping people, quote, focus on transcendent meaning, purpose, and values, chaplains provide spiritual resources that benefit patients, families, and staff members in healthcare organizations. So keeping with this sort of language of spirituality, many departments have actually changed their names from being departments of chaplaincy or pastoral care to now being departments of spirituality or spiritual care services to reflect this sort of broader orientation. Some healthcare organizations have been more receptive to these perspectives and to working with chaplains as part of interdisciplinary healthcare teams. I can say more about this, but I actually divided the hospitals that I looked at into groups based on sort of how professional versus traditional their work was, how they related in the hierarchy, how they related to other people in the healthcare organization. So the last layer that I want to talk about here before I wrap up is about the healthcare providers themselves. And this is what I learned by spending the year in a medical and a neonatal ICU, both at the same hospital. So I shadowed nurses, and then I did a lot of interviews asking healthcare providers how they see religion and spirituality coming up in their work and how they respond. Now, I write about this both in terms of their professional work as well as in terms of their personal responses. And I'm going to talk here just about their professional responses, which mostly involve trying to accommodate patients' religions or spiritualities up to the point that they see it coming into conflict with medical recommendations. So staff spoke a lot about religious objects people bring to the units. They talked about little religious icons that parents bring in that they put in bags with labels on with the baby's names, and they put them in the bed, or they attach medals and things to adults who are in a medical ICU. So they talked a lot about these sorts of objects. They talked about rituals, and especially in the neonatal ICU, they talked about baptism. So most of the nurses that I interviewed were Catholic, and as one told me, quote, any baby that's going to code or it looks like it's going to pass away, all the nurses in the NICU will baptize it, whether they're Catholic or not. If the baby's dying, another one said, and there's a question in the mind of whether the family would want them baptized, we do it by sprinkling water on the child's head and saying a short prayer. If they, the parents, didn't want it, we don't have to mention it. A Jewish nurse actually talked to me about how she learned to baptize babies 20 years ago when she started in this unit, and she was pretty uncomfortable with this. So she told me that she asked the sort of resident chaplain priest, that this made her uncomfortable, could she be doing this? She was Jewish, and the priest said, don't worry, it's just a lovely thing. So there's a real emphasis on baptism, and I think you can see from these examples that this is maybe not about the families, this is about the healthcare providers, right, these Catholic nurses, and what they think is important. Staff also spoke a lot about end-of-life rituals and about prayers, with some saying that they will stand quietly when there's a prayer, and others accepting invitations to participate by holding hands or standing with a family. Again, in the media, we see a lot of debate about, should healthcare providers pray with patients. None of the people that I interviewed talked to me about offering to pray with patients. They all talked about what happens when patients or families ask them to participate. There are always exceptions, but I think we need to sort of keep the big picture on that one. So in the words of one nurse, if they, a family, invite me to join in prayers, I definitely will. If they're holding hands around the bed and I'm doing my work around the bed and they reach for my hand, I'll put down my materials and medicines or whatever and join them. All of the participants that I talked with participated only if invited and only if they felt like it didn't interfere with the medical care they were providing. So implicit in these and other examples is the strong sense among staff that religion and spirituality is relevant in times of crisis, when difficult decisions are being made, and at the end of life. Some of the nurses in the medical ICU told me that they actually sort of forget about it at other times, but they always try to remember when someone is dying, reflecting what for many of them as practicing or non-practicing Catholics are their ideas about last rites. The nurse manager of the ICU, so the head nurse, was actually insightful in this regard when she told me that she wants to offer religious or spiritual care, but she isn't always sure how to do it. And so she sort of haltingly told me the story. And the story basically, that she was telling me, she said, I stood with a wife and a daughter of a man who was being whisked from the ICU into surgery. And she said to me, it occurred to me that maybe we should offer a chaplain to come in and say a prayer with this family or to provide support. But she was nervous about how to do that. She said, I was aware that they, the family, might think that I was alluding to the fact that this man should get last rites before he goes. She didn't know if the family was Catholic, and she didn't want to scare them. So she just sort of fumbled around and didn't know what to say. They picked up on her discomfort, she said, and after some misunderstanding, she managed to say to them, I don't know what faith you are, but it would be something that I would want someone to offer me. So this is a head nurse wanting to make an offer, but really not being sure how to do that. And in this particular unit, the chaplain there was a Catholic priest. He really only saw Catholic patients. A lot of the staff really didn't understand what he was doing. So one of the really important things to sort of just know about chaplaincy in general is that it varies from unit to unit, from hospital to hospital, from one hospital across the street to another one on the other block. So this story points out several things. The lack of training in how to offer chaplaincy support in this unit, the assumption that many have about chaplains and death, and the importance of unit culture. Spirituality was addressed much more consistently and professionally in the neonatal ICU where I spent time, and there was a trained pediatric chaplain who actually saw sort of all the patients in that unit. So there's more to say here, but let me conclude with what for me were the 3 take-home messages from this project in general, and then I'm hoping we can talk, because that's always more fun. So religion and spirituality are present in big academic hospitals in multiple ways. This is obvious. At the broadest level, I found healthcare providers using a range of languages to think and to talk about religion and spirituality that are not always mutually understood. Chaplains increasingly frame their work in terms of spirituality, where the nurses and doctors I spent time with mostly talked about specific religious traditions, mostly Catholicism in the particular hospital where I was. There were rarely translators available to help these healthcare teams understand what they meant when there was this sort of talk about spirituality and religion, and to think in a regular and systematic way about how it might be important to patient care. I see chaplains using this language of spirituality as a kind of least common denominator way of talking about meaning. So the images of flowing water, nature, light, modern art in chapels are really sort of showing this kind of in material culture. This sort of broad approach may enable chaplains to connect with as wide a range of people as possible and support them in their quest for meaning. But we also need to think about the fact that not everyone believes that all people are spiritual and see this talk of spirituality as a legitimate source of authority for chaplains' work. Talk of spirituality also doesn't solve the problem of religious diversity. The Catholic or Muslim patients who maybe don't know what this means, it more just glosses over those differences. I'm concerned here about the lack of knowledge about a range of religions I saw reflected in healthcare organizations and amongst healthcare practitioners. So these different sort of religious and spiritual languages led to a paradox in which religion and spirituality actually seem to be most present when they're visibly absent, and absent when they're visibly present. What do I mean? It's the chaplains who are the visible, present, professional carriers of religion and spirituality in hospitals, but they're increasingly removing religious symbols from their chapels and explicitly not really talking about religion, more talking about spirituality in their work. It's when religion seems to be visibly absent in an ICU in the work of doctors and nurses that I actually heard talk of traditional religious rituals and practices and objects sort of more present. So this was one of my key take-home messages. A second key take-home message is about death. And it's simply to point out that when people in healthcare, chaplains and staff alike, think and talk about spirituality, it is very often connected to end-of-life situations. From the mortuary chapels, to when the nurses in the medical ICU always try to bring up these topics, to when the chaplains are called. Many of the healthcare professionals that I met actually reinterpreted my project as being about death. So they tended to call me the free coffee girl because I was giving out coupons in exchange for people's time to talk to me. I would give them coupons for free coffee at the hospital coffee shop. But the nurse manager in the medical ICU that I was talking about earlier actually introduced me to someone as that person doing the project about death in ICUs, which I thought was fascinating because I didn't ask a single question about death. So I said religion or spirituality, and people heard death. Chaplains provide a lot of rituals around death for hospitals, for employees, for the institution, but in so doing, they can get caught in a catch-22 where people think that that's sort of all that they do. And I think that there's a real potential for chaplains actually to bring new perspectives to death in hospitals. I think that they do this in some cases, but I'm not sure that their colleagues are listening carefully enough to hear it. So let me just tell you one final story. This again is about Chaplain Meg, who has since retired and moved to North Carolina. It was not unusual to hear nurses refer to some patients as miracle babies in the NICU at the hospital I studied. These babies survived despite poor medical prognoses. Their healings were miraculous, nurses told me, but they differed in what they saw as the source of the miracles. For some, these were miracles of medical science. In Nancy, a nurse's words, "I don't think it's a miracle like they talk about with the saints and all that stuff. It is a miracle that our doctors and nurses and staff can do. We're a very good hospital with a good reputation, and we can do miraculous things. It's not like somebody came down and put a magical sprinkle on to make the baby go, a certain way." Other nurses were less sure of the source of miracles, and still others attributed these healings to divine sources. "I guess if anything, it always goes back to God," Tamara said. Another nurse, Hannah, spoke of a miracle that happened in another ICU. I can't even tell you the whole story because it was a while ago, but some of the nurses actually went to Rome because this person who facilitated the miracle was a Catholic nun, I guess, and sainted or something. While nurses in the neonatal ICU talked about the source of miracles, pediatric chaplain, like the chaplains at the other hospital I studied, tend to ask broader questions about what a miracle is and what makes something a miracle. When I spoke with Chaplain Meg about the so-called miracle babies, she responded by thinking about what makes something a miracle. "I see miracles here every day," she told me. "Whether others see them as miracles, I don't know. I think it's very subjective. I think a miracle is in the eye of the beholder." Meg went on to talk with me about a young woman she had met years earlier at the hospital who was born with a congenital heart defect. She was not expected to live, but did, for more than 20 years. She had several successful surgeries, Meg remembered, and married and lived a relatively normal life. Meg met her while she was waiting for a heart-lung transplant, which did not come in time. After she died, Meg said, her mother felt like it had all been for naught. And I said, "Well, I'm not so sure I agree with you." When her mother asked why, Meg explained, "I think you had a 25-year miracle. This was a child that you didn't expect to ever come home. You had her for 25 years. And not only did you have her for 25 years, but she was able to live and have a very functional life. She knew what love was about. She knew what kindness was about. That's a miracle in my mind." Turning from this story back to me and the miracle babies, Meg told me, "I think most people are looking for the big miracles. And I think most miracles are not big. They're small. They come in the minute facts of life. Sometimes they all come together, so you get a big miracle, but it doesn't happen very often. Usually they're little things that happen. A patient has a good day who's been absolutely miserable and non-communicative with the family, and the family doesn't think they're ever going to have a chance to say goodbye. That's what I think of as miracles." So I like this story, and I like it because I think when we listen carefully to some professional chaplains, we can actually hear a very different way that they think and a very sort of important perspective they bring to these questions about death in hospitals. But I fear that many in healthcare are not listening carefully enough to what chaplains have to say. And in my experience, people in healthcare tend to mostly be concerned with two outcomes. One is better health, and the second is lower cost. I care about both of those things. But I think paying attention to chaplains and to thinking about religion and spirituality more broadly sort of raises the importance of thinking about a third outcome, which is care that's more compassionate, that better meets people where they are. So since this book was published in 2003, I've been working on projects about chaplains in other sectors, airports, ports, municipal settings, the halls of Congress. I can talk to you about this if you're interested. But I've also been working on this big project that Marie mentioned, and I just want to tell you a little bit about it in case there are any chaplains in the audience. Here's the ad. So this is a big project with George Fitchett, who's a chaplaincy researcher at Rush Medical Center in Chicago. And at the end of my book, I make a series of suggestions about how I think chaplains can work better with people in healthcare. And many of the suggestions have to do with training. And the problem, from my perspective, is that chaplains need to be trained with healthcare providers. They need to learn how to do this translating from the beginning. And the fact that chaplains are trained in divinity schools apart from public health and medicine and nursing is really a big part of the problem. So I imagine a whole new way to do this. It's never going to happen because, time, resources. But we did get this big grant from Templeton, and the goal here is to send 16 board-certified chaplains to public health school so that they will be able to sort of learn and be immersed in the kind of public health culture, ideally, and write theses about aspects of chaplaincy practice that we hope can inform the field and inform how they think about what they do. So the goal here is to have chaplains learn a bit about research, but not because we want chaplains to become researchers. It's because we want chaplains to become translators. And we think that knowing something about research will make them better translators in their settings. So that's one big arm of the project. The second arm of the project is focused on the centers where chaplains are trained, this clinical pastoral education. And we have about 70 grants of about $5,000 each that will go to CPE programs that are interested in bringing research into their training of chaplains. And then there's going to be a free online course that's available to members of any professional chaplaincy organization in the US. So what we're trying to do is bring this perspective to healthcare chaplains regardless of sort of where they are in the country, what their level of expertise or time or anything is. So if there are chaplains in the audience, I'm happy to talk more about this even after this, or tell your friends who are chaplains. So I'm going to stop there. I look forward to your questions and our conversation. Thanks very much.